Maybe. Did it work? You guys see me? Sweet. Awesome. Cool. Right, one sec. Share screen. All right, so this is going to be a shorter lecture, but it's going to be a little more complicated. So if we need to slow down, we need to work through it together. Y'all speak up and let me know, hey, let's slow down. Let's work it through a little slower. Bunch it up from the beginning. Cool. All right, everybody ready? We got 7 minutes. You're ready. All right, cardiac muscle and electrical activity. So, as a little wrap up from last class on Tuesday, so we went through the anatomy of the heart. So we remember that there's something special about the heart in that it's got myocardial tissue, it's got cardiac muscle as well, and that's its own special thing, right? We talked about blood flow. So the blood comes in the vena cava, it dumps into the right atrium, to the right ventricle, through the pulmonary trunk, into the lungs, where it gets reoxygenated, sent back into the heart via the pulmonary veins, and then into the left atrium, into the left ventricle, and out through the aorta, okay? So that is the flow of that, right? And then we talked a little bit about the cardiac cycle. So there's some certain words that were associated with that. So like preload and stroke volume and cardiac output and all of that. So that is kind of dealing with the blood moving through the heart. All right, today's lecture is going to be about how the heart moves, okay? So just like any other muscle, it's innervated by a nerve, and it's actually innervated by a couple nerves. But we are going to kind of go through that a little bit too, okay? We're going to work on ECG stuff and how to like recognize things on ECGs. Not anything crazy. I don't need you to know what you're not a cardiologist. I don't need you to glance at a heart or at each ECG and be like, this person has a left ventricular bundle branch. I don't need that. But you should be able to at least know, like, if I give you this line of the EKG, what are we looking at, for instance? So that's a little confusing. So when we get there, feel free to have questions and bring them up. Other than that, let's get started. Cool. So the structure of cardiac muscle. So as we talked about in the lab, there's a couple things that are special about heart cells, okay? Specifically myocardial cells, okay? So they are uninucleate, means one nucleus per cell, right? There are branching fibers. So you see how these branch off kind of like a tree and they're not linear like a skeletal muscle would be. There's large numbers of mitochondria. We need a lot of energy to move constantly, okay? So a lot of mitochondria, a lot of like backup systems in place so that if one thing stops working, another thing will work. There's striations, obviously, because of the actin-myosin. It's autorhythmic, which means they will beat on their own. So they actually don't need innervation by the nervous system. It helps you not die, but if you don't get direct innervation from the nervous system, they'll actually be on their own in a perfect solution, right? So you can't just like take a heart out and it's beating like what's the movie? Trying to Pirates of the Caribbean. It's not just like beating like, I'm going to jar of dirt. No, it's not doing that. So it you have to keep it in like a solution that's like perfect environment for the heart, right? And it doesn't last like a very long time, but it can do that. It has that ability, and the reason for that is if for some reason the nervous innervation is compromised, then you need a backup plan, right? Or you die. Um, Intercalated discs. So those are these areas right here. There's like discs between the um, uh, the myofibrils right here, or the myofilaments right here. There's areas between that, and they have what's called desmosomes. These are just areas where they speed up the impulse. Okay, so the point of intercalated discs is to shoot that impulse through even faster. Okay, so you can see right here, like if you're going to shoot an impulse from this end to this end, or this end to this end, it would be really helpful if you could shoot it from this end to this end, but on the way, pick up a little detour route and make sure that your buddies are coming with you, right? If you're in action potential, you wanna like spread that message, right? Because the message is, hey, pump and don't die. Um, Functional syntium, I think I forgot to look up that word before I started, but I'm pretty sure that means that they work together. That's just a fancy word for that. They have a long contraction time. So compared to like a skeletal muscle, it's just like cardiac muscle is think of it. No, it's a terrible example. It's smooth and steady, but it's not like responsive, right? Like you're not using it to like jump out of the way of something. So you don't need all the skeletal muscle contractility speeds, right? You're just keeping it steady, right? And they're not going very far. Like one muscle, like from here to here, might be like a big length. Cardiac muscle is just doing this. That's all. Okay. They have a long absolute refractory period, so like that cycle takes a while. Okay. What do we got down here? That's some cool stuff. Myofibrils composed of myofilaments arranged in sarcomeres. Yep. So all the same thing that you're used to for skeletal muscles. T-tubules transmit the impulse. Yep. Numerous by property from energy. So yeah, basically all that we just said is right here. The intercalated disc connects the cardiac muscles and consists of desmosomes and gap junctions. That's a good point. So desmosomes are like they speed up the thing. Gap junctions are just a type of junction between like if you're gonna send, think of it like Static Shock, the superhero, where he just like touch stuff and it like jumps, the electricity jumps from one to the next and like it gets there faster. That's kind of what's going on in gap junctions. So that was like a really stupid basic way to explain that. All right, conduction system of the heart. So this is the real meat and potatoes of what we're going to talk about. Okay. All right, so we're going to talk a little bit more about this in lab, but what you need to know is the conduction from the heart. It comes from your sympathetic nervous system, okay? And it jumps up to here, to right here, where this little spot is called the sinoatrial node. And from there, it kind of like spiderwebs out and jumps around to cover the whole atrium, right? So there's branches that go around the right atrium, there's branches that go around the left atrium, and all of these like because you want your atria to contract at the same time, all of this happens like immediately. So as soon as you can see impulse, atria contract, right? And that's the whole point of the sinoatrial node. So that's the pacemaker, or no, it's not. It is conducting the sympathetic nervous innervation through the atrium. Okay, so real fast, right? All right, so the from there it goes to here, and all of those pathways loop back around, and they end up at the same exact spot, right? And so that little spot is called the atrioventricular node. So the AV node. So the SA node and the AV node. Okay. And a node is basically just a bundle of nerves. Okay. So that's a spot where a whole bunch of nerves meet up, right? So they go from one nerve to the SA node, they all meet up, they disperse, and then they come back around and meet up at the AV node. From there, they travel down the bundle of His, which you can see goes behind your pulmonary trunk. You don't need innervation in your pulmonary trunk, so you don't get that. And it goes into the septum. This right here is the septum, okay? And then from there, you have to branch off to the right and left ventricles, right? Just like we did up here, we're doing the same thing. There's a name for that. It's the bundle of His. I wonder if His is an old white man. Let's find out. Bundle of His, Dr. His. His bundle is named after, let's see, is it a white man? Right in pacing. Yes, here we are. Wilhelm His Jr. This is Dr. Hiss. A white man. Look at that. Isn't that amazing? Science is awesome. Okay, so they go through the bundle of His, or the atrioventricular bundle, if you don't like white men. And then from there, they separate into that right and left bundle branches, okay? And the right one goes to the right ventricle. Go figure. The left one goes to the left ventricle. Go figure. And as you can see, it's coming down and shooting like towards the back, towards the front. Think of like an umbrella. Like if you've got like an umbrella and it's got the things like an upside down umbrella, it's kind of branching out from there. Okay, and that branching is called Purkinje fibers. And the only question you need to ask yourself is, Dr. Purkinje an old white man too? And let's find out together. Purkinje fibers. Let's go to Wikipedia, where I learned most of this stuff. Entomology is named after a Czech scientist, Jan Evangelista Purkinje. I don't know if that is Czech. And here is Dr. Purkinje. Oh, look, he looks the same. Okay. So that is Dr. Purkinje, and he named these fibers after himself because he's very selfish. And we don't really have a good name for them, but they are the Purkinje fibers, which is fun to say. So those branch all around the bottom of the ventricles, okay? And from there, so you can kind of see it doesn't start branching quite yet until it gets to the apex, and then it branches, okay? So the reason for that is, what would happen if it started branching up here? Somebody throw that in the chat. If the electrical impulse to the heart started here, where it branched, what would that stimulate? Anybody? Anybody? You can also shout it out too. Love to hear voices. I'll just stare at my camera until somebody says something. You don't know
No,
sex.
no clue.
No clue. That's fine. Thank you for responding. If your electrical stimulation starts here, you're going to stimulate all these cardiac cells right here. Why is that bad? It's bad because think of like milking a cow. You won't start from the bottom and like shoot it up, right? So the same thing. Like if you squeeze the top of the balloon, you're not going to get any air out of the balloon, right? So yeah, a misfire. So you'll squeeze the top, and then nothing will come out when the bottom gets the thing. Okay, so it's just like if you squeeze. So you want to like squeeze up, right? Squeeze up. like a upside down udder or something. But you want to squeeze it out, right? So you don't want to start up here. So it branches and it stays in the septum, and then it branches out. Okay. And you can see it branches out to like all the papillary muscles into the like into the wall of the ventricles, all over the place. So everything's getting stimulated. Thank you, Mr. Pertinci. Sorry, Dr. Pertinci. Cardiac conduction. Does everybody understand that? Are we good? That it's pretty straightforward, but any questions on that? All good. Ariana speaks for everybody. Okay, so, all right, cardiac conduction. So, the sinoatrial node and the remainder of the conduction system are at rest. So, heart not beating, right? We're just chilling, all right? The SA node initiates the action potential, which it gets from the sympathetic nervous system, okay? From there, that action potential shoots through the atria, okay? And then the atria contract, okay? And then, because you don't want the whole heart to get the message all at once, you have the AV node, which slows it down. So all the AV node is doing is getting that and going, oh, and then they're going, what? And then they just keep going, okay? So the AV node is just like, be like, slow down. And then you slow down. It's like the lifeguard at the pool when your kids are running and you blow the whistle and your kids slow down for half a second and then they keep running. That's exactly what the AV node does. It's a lifeguard, okay? So following the delay, the impulse travels down the interventricular bundles and then out to each individual bundle, okay? So we're out, now we're squeezing the ventricles. And you can see like it starts here, it's sending the impulse up, okay? So we're squeezing from the bottom, now we hear, okay? So it spreads to the contractile fibers in the ventricle, and the ventricular contraction begins. Okay. Click on this. It's good. There's videos on the links and all the other stuff in this section specifically. It's really helpful to watch the anatomy work. Okay. That will like really get it locked in, because if you're just going stepwise and like it goes from here to here to here to here, it will not make a whole lot of sense. But if you watch it, you'll be like, holy crap, that's awesome. So that's how that'll work. All right. So the action potential of cardiac conduction. So let's start with this. So in your cells, right, you have a net negative of a charge, right? So inside the cell, it's roughly negative 40 millivolts, okay? So, and the reason for that is because you have K in the middle, right? And Na outside and calcium outside. So there's a net negative charge and there's a net positive charge outside the cell, okay? So as we go to depolarize, so we open the channel so that sodium ions, so circle K inside, what's outside? Na. So Na is going into the cell, and as we're doing that, we're slowly bringing up, well, it's not really that slow, but we're bringing up the membrane potential of the cell, okay? So we're going from negative 40 up to negative 20, up to 0. This is like roughly 18 millivolts, okay? And that's pretty consistent. It's not important that you know. The only thing you really need to know is that it's negative, and then it gets positive, and it eventually reaches a threshold, like a critical point where it gets too positive and it goes, oh, slow this down. So then you have rapid depolarization, okay? So, sure, why not? So at that point, the ion channels will shut, well, they'll just snap shut in the video. We don't need that crap anymore. And then it will reach a threshold and initiate the spontaneous depolarization and contraction of the cell. So it shuts the ion channels, and then it shoots all the positive ions out. Okay, it's like get out. And to do that, remember our active transport. So if you're shooting potassium out, you're gonna bring sodium in, right? So it's going in a net positive direction or a net negative direction because you're bringing in, you're sending out more potassium than you're bringing in sodium, right? Um, so your potential goes down, and then it's gotta kind of balance itself. So it'll slowly let sodium back in, and then there is a rapid influx of calcium. So again, this is a cycle, right? So that's exactly what's happening right here. So there's a rapid influx and depolarizing, and then it's repolarizing. So depolarizing, repolarizing. So it's going, I need to get back to where I'm going, and then it comes back here. It's so rapid that it will overcorrect itself, right? So you're going from negative 40 up to positive 20, 18, and then rapidly down to negative 60. It's going across the interstate, across 3 lanes, rolling back the other lane, and then ending up back in the same lane, okay? So there is a slow, but it does that slowly because it doesn't want to jerk the wheel again. And then the deer jumps out in front of it, and it jerks the wheel, and then slowly gets back in its lane, okay? So just kind of think of it like that, if that helps. If not, just, I don't know, think of it a different way. All right, so the thing to note here is there's not a resting potential. So in most other cells, there is a resting potential, which is a specific number that cells live at, that they're at rest, okay? Cardiac cells don't rest. Got it? Got it. All right, so the action potential in cardiac contractile cells. All right, so right here is where those ion channels open. So this is negative 60. We're going up a little bit. Sodium channels close. And then we let in a whole bunch of calcium, and then it plateaus right here because it's like, oh shit, oh darn, calcium. And then they close and don't let any more calcium. And then you repolarize the cell, and the potassium channels close, and then you kind of stabilize a little bit. There's the net refractory period, and then the voltage gated ion channels open up again and shoot all that through, and then it kind of slowly stabilizes. All right, that's different than skeletal muscle. Look at that. And what that does is it creates a more controlled contraction. Okay, so the action potential for heart muscle is next to skeletal muscle right here, and just notice the difference, right? If you need to jump out of the way and you're like, matrix, you need that action potential to go, and you need to contract really fast, right? For heart, you need it to stay steady. You don't want it to shoot up and down. Like you don't want it to shoot all over the place. That's really bad for you, okay? It allows it to fully contract before another electrical event can occur, okay? Any questions about action potential in contractile cells? Ariana, can I keep going? Thank you. All right. This is confusing, okay? I'm just going to give you a disclaimer. I'm going to explain this not in a very good way, and you're going to be pretty confused, especially on the next slide. What I want you to do is calm down. There's a lot of good resources. There's a video on the video links that kind of explains this a little like more clearly. And then there's also there's a bunch of great videos out on YouTube. Like it's like really popular subject for nursing students. You need to know how to read an EKG if you're going to be a nurse, right? So there's a lot of resources out there. Again, my recommendation: this book, stupid easy to understand. Okay, you'll read it in 3 hours and you'll know everything about EKGs. Okay. All right. So the point of an EKG or an ECG. And by the way, EKG, ECG, same thing. So they're interchangeable. We're measuring the conduction, conductivity of the heart. We're not measuring anything in the heart. What we're measuring is the conductive motion, right? And we're using that information to figure out what's going on in the heart. So if you see an area of slow conduction, you can infer that that message is not being sent through that area. So you can go, okay, well, those cells, either they're dead and they're not sending the message, or there's a blockage somewhere that's causing that message to not be sent, or there's a blockage in the artery, and they're not being able to get enough oxygen, and they're prioritizing getting oxygen over pumping blood throughout the rest of the body. Okay, so all of those are bad, and all of those are things that you can pick up from an EKG. Okay, so we're using the EKG as an indicator of what's going on an anatomical level. Okay, so and it's in a triangle. So if this is the heart in the middle, okay, you have leads above, below, left, right. Okay, so this is the right arm lead. This is the left arm lead. This is the left leg lead. Oh, other thing about arm leads, you might see the dots here instead of here, or here instead of here. Same thing on the other side, here and here. It's not really important where they are on the arm. It just needs to be somewhere close to the arm. So we're creating a frame, and then we're visualizing everything in that frame, basically. Okay. Then there's ventricular leads, so the V's, the V1, V2, V3, V4, V5, V6, okay? Those are placed around the sternum, and what we're doing here, oh, hang on one second, I forgot to mention something. The arm leads, like RA, LL, LA, like these things are, and they have A before them. So remember, arm, VL, VR, VF, okay? So what this is doing is this is creating, think of like an x-ray image straight on, right? So you're creating a frame around the heart and you're looking at it straight on, okay? And then what the ventricular leads are doing is they're creating a horizontal frame. So imagine you're looking straight down at the heart now and you're looking at it on a different plane, okay? There's a saying in X-ray. Any of you guys go into X-ray? One view is no views. Two views is one view. Okay. We're looking at it in two different views so that we can isolate problems. Okay. All right. So 1, 2, 3, AVR, AVL, AVF. Those are all vertical views. V1 through V6, horizontal views. Okay. I think if we're in lab, we would make each other like EKG each other, but we're not doing that. So you're welcome to like, I don't know, buy an Apple Watch or something. But yeah, so you don't really need to know how to do that. If you go on to something else, you'll learn how to do that. Don't worry about that. But just for the sake of like understanding them, this is what we're looking at. Okay. So lead V1. Oh, the other thing. Think if the electrical conduction is starting from your nervous system to your SA node, you're looking at it at different planes. So if you're starting from your right arm, right? So AVR, you're looking this way through the heart, okay? And what that's important for is because you want to keep track of what that conduction is going to hit first. So if you're looking at AVR, you're going to look at first the atrium, then the ventricles, and the apex of the heart. Okay, you're looking at it that way. If you're looking at it from AVL, you're looking at it this way. So you're going to start at the left atrium through the like probably through like the valves, and then end up on the right ventricle, right? So left atrium through the right ventricle and then out. Okay. Same thing for all the other leads. So if you're looking at it, just think of it like you're looking straight through, like you're shooting a vector through the heart, and the things on that vector will tell you what's lagging. Okay. Same thing with V1. So right here, you're going to start here, and since the septum of the heart sits like kind of like this, sorry, kind of like this, it's looking directly at the septum. Okay. The V2 is right next to it, so the same thing. We're looking at it at different angles, so you might pick up something slightly here, and then heavily here, and then even more heavily here, right? The V2 and V4, or V2, V3 are anterior views of the heart. So you're looking this way, kind of. And then V5 and V6, you're looking laterally at the heart. So that can tell you what's going on the posterolateral part of the heart. So, question. What if you're looking V5, V6, posterolateral, what are you trying to get a picture of if you're looking at V5 and V6? Throw in the chat. Left ventricular, yes, the left ventricle. Okay. And why is it important that we understand what's going on in the left ventricle? It pushes blood to the rest of the body. That's correct. And that is important. So we want to know what's going on with that thing. Okay. So, all right. So, left ventricle. So you're looking at it at 3 different angles, basically 6 different angles. But you'll look at a couple of these. You'll look at 1,000 of these, and you'll start picking up on stuff, and you'll be like, oh, I can see that starting to get picked up here. You can follow it through V2, V3, and then it disappears. So like, there's definitely something going on the septum or something like that. You'll start like picking that up. Okay, V1. No, where did it go? Oh my god. V1, V2, V3, V4, those aren't like wildly important. There's a lot going on right here. So like there's interference that might happen that you might pick up on something, and you might be like, I don't really know, like maybe we gotta confirm it kind of thing. So it's not always a confirmatory test. 2, 3, and AVF. These are looking at this part of the heart, right? And those are important, okay? That you'll see some stuff. Like when stuff is wrong, you're gonna be like, oh, that's one. And you'll see it there, okay? Okay. There's a lot going on here, okay? And I need you to know everything on here. Not really. So this is up here, up top. This is kind of like a colorized description of what we just talked about. So if you're looking at the inferior part of the heart, you're going to look at 2, 3, and AVF, right? If you're looking at the septum, it's going to be V1, V2. If you're looking at the lateral wall, it's going to be AVL, V5, V6, right? So 2, 3, and AVF right here on the inferior, V1, V2. And this will tell you, and you'll see stuff wrong with that, and you'll be like, oh, that means it's dead, which is bad, okay? So, like, you'll see stuff, and you'll be like, oh, okay. So, if we all remember what a normal QRS looks like, here we go. Here's a normal one. I'll come back to that, okay? So, a normal QRS and EKG. So, we have waves, and then a complex, and then a wave, okay? So what's happening right here, this is called the P wave, okay? So this first little bump is called the P wave. This is the electrical conduction. It's hitting the atrium, they're depolarizing, and then they're contracting and repolarizing at the same time. We're contracting and then repolarizing, okay? So this is left atrium depolarization, right atrium depolarization, atrial contraction right here, okay? So if you see problems here on the P wave, the atrium is messed up, okay? Now, this is ventricular depolarization, QRS. This is ventricular contraction. And then over here is ventricular repolarization. So one thing you're going to notice about this, and you're going to go, hey, Matt, the atrium depolarized. What the heck's going on next? Because this is contraction. When did they repolarize? That's a great question. And the answer is they did, and it's right here. But it's shielded by a lot of other stuff going on that's more important, okay? So you're not going to pick up on atrial repolarization. like you will ventricular repolarization. Okay, so this is ventricular depolarization and then ventricular repolarization. So you're gonna see. Okay. All right. My kids need to go pee, just in case anybody's wondering. All right. So you're gonna see all of that in a normal EKG. Right. So if you look, you can see that like this is bad. All right. You see how this ventricle is not repolarizing like it should? This is called ST segment elevation. This is a STEMI. And that's like the worst thing that could happen to you. Okay. This is really bad. Your ventricles are not repolarizing like they should. Okay. This is an acute process. This is happening right now. You're about to die. Got it? You can pick that up on V5, V6, right? Because on V5, V6, you're looking over here. You're looking at the left ventricle. Okay. So if you see ST elevation on the V5, V6, that means there's left ventricular ischemia, right? If you see it on V1, V2, it's over here, right? So it's bad, but it's not as bad because it's better that your right ventricle works than your left one. Or it's better than your left ventricle works than your right ventricle. Okay. Non-STEMI. So these are things that you look at, and they're not ST elevated infarctions. Okay, so the ST is not elevated, and when we talk about elevation, if this is the baseline right here at 0 millivolts, this line is moving up. Okay, so this is going up a couple blocks, and that's elevation. Or if it's going down a couple blocks, that's depression. Or if you're really sad and can't get out of bed, that's also depression, but a different kind. Okay. So ischemia is bad, and it can cause ST elevation or depression or T wave inversion. That's another thing. So sometimes your cells might try to be repolarizing, but they're not doing it in the right way, and it's causing it to be picked up backwards, right, on the thing. So that tells you some stuff too. Okay. Classic STEMI. This is what it looks like. There's also, let me show you something. Let's see. There we go. This is called a tombstone STEMI. So ST elevation, no T wave whatsoever. The T wave has like combined with this, right? So this is really bad. And this is called ECG tombstoning. And for good reason, because it means you're kind of bad. Okay. So like you can see how extreme it can get sometimes in like really serious issues. Okay. All right. So those are all things that can happen. Lateral infarction. So if you're looking at the heart laterally, you'll see that in 1 AVL, V5, V6. Okay. If you're looking at it inferior, it's mostly 2 and 3, and then a little bit of AVF. If you're looking these are other things we'll talk about in a second. Anteriorly, you'll put that in V1, V2. But you can see, like this one, for instance, right? You can see clearly there's something wrong in V1, V2, V3. V4 is starting to look a little normal. V5 is looking a little normal. V6 is looking pretty close to normal, right? So really what's happening is something really bad on the anterior side, and you're kind of picking up remnants of that all the way through the system, okay? Bundle branch blocks. So if we remember Dr. Hiss's bundles, you can have a right bundle branch block or a left bundle branch block. And those create very specific ECG findings. So V1 and V6, right? Because you're looking at it front and side, it's gonna cross over and create like a pinpoint area right there. And then left bundle branch block is the same thing, V1, V6, because they branch at the same spot, right? But if it's affecting the anterior side, you'll see some anterior side issues. If it's affecting the posterior side, you'll see posterior side issues, okay? These are classic, like this T-wave inversion, right bundle branch block. And a QRS complex that's widened. So normal QRS should take less time than that. So if it's greater than 0.12 seconds, then you have an issue. If it's longer, if your QRS is taking longer, and if you're seeing a whole bunch of squiggles and they're stretched out, that means it's taking longer for the signal to get through. It's still getting through, but it's taking longer for them to get through. So that's important. So if you have a QRS complex that's longer, that means it's slowing the signals down. So you can pretty much infer that it's going to be an issue with the mono branches, right? Fun fact: when I was in college, I had to memorize like 40 issues, which is why I bought this book. I'm not going to make you do that because this is anatomy, not functional anatomy for electrophysicists. So that was super fun. Okay, so P wave, QRS, T wave. There's also segments. So the PQ segment. So P between here and your Q wave, right? So PQ. The QRS complex is this entire thing, and then the ST segment is right here. So sometimes you might see like an elongated ST segment. So if you see that, it means the ventricles are taking longer to repolarize, right? So this whole thing from start to finish should be about 1 second, right? You should get a little more than 1 minute. So 60 to 80 beats per minute is normal. All right, normal. So P, QRS, P, QRS. 1 is going to be your classic EKG look, right? 2 is going to be really 2 is going to be your like very classic EKG. Okay, that's what you're going to look at to see like if this is a normal EKG. You'll look at 2. Okay. AVF is important to look at like the left ventricle, right? V5, V6, same thing. They're important to do the ventricle. Okay. It highlights, so all of those are picked up right here. So these are 12 different blocks. So they're showing 12 different locations, right? And then down here, what we're doing is we are highlighting a couple important ones. So V1, 2, and V5. So we're looking at the front of it, the back of it, and then like from here to here, because we want to make sure that that signal is getting all the way through. Okay. Click on these, watch the videos, learn from somebody except me. Common ECG abnormalities. Okay, so there's blocks that can happen. There's fibrillations that can happen. So atrial fibrillation. If your atrium are fibrillating, that's not good. Okay, it's not as bad as if your ventricles are. Atrial fibrillation is not great either. Okay, so remember from the cardiac cycle, you get most of the blood into your ventricles from passive filling, right? So the atria are only pumping that last little 20 milliliters or whatever into the ventricles to kind of stretch them out. Now, your ventricles aren't going to be as efficient because they're not going to be all the way full before they fire, but you can live with AFib, okay? It's uncomfortable, but you can live with it, all right? And it's a problem with the electrical pattern before the QRS complex. So there's something going wrong with the electrical pattern in the atrium, but it's getting pretty much normally through the QRS, okay? And you'll be able to kind of see that. It's thready. You can see how there's different, your ventricles are firing at different times because it's like, I think the signal, was that, yep, go. Was that the signal? Yep, go. And so they're like doing that whole song and dance, trying to pick up the signal where somebody's screaming in the background, basically. That's it. Close the door. Thank you. No, you're gonna close the door. Bye. All right. So so that's what's going on in atrial fibrillation. So in ventricular fibrillation, a lot of bad things are happening. So your ventricles are fibrillating, they're going like this, and they're doing the same thing that the atria were doing, right? And you can't really get the message across. And if you can't get the message to the ventricles, that's bad because they're doing all the work, especially the left ventricle. This is very bad. Okay. So, what would you expect to happen to the pulse if you have the ventricles aren't squeezing? Anybody want to take a guess? Birdie, fake, yeah. Is a weak pulse a good thing? No. So yeah, so you'll be able to tell, okay? This is a shockable rhythm. You need to shock it to get it back in normal rhythm. This one, you don't really need to do that. The reason is the ventricles are working. You don't want to do that. You don't want to mess with that, okay? Um, not, a common misconception when it comes to EKGs, and this is something that I'm going to ruin Grey's Anatomy for you for the rest of your life, okay? So if you're watching Grey's Anatomy and there's anything except VFib or like one other thing, it's not a shockable rhythm. You'll kill somebody doing that, okay? If you shock somebody with a block, it'll just reset their electrical conduction system that there was nothing wrong with, and you'll basically flip because the shock is opening all those channels and like pushing the ions the correct way. So they're going the wrong way, and then you shock them, and then it goes the right way. Okay. When it comes to like this, there's these ion channels are all jacked up. Okay, so we need to shock them and get them going the right way. When it comes to like things like this, like atrial fibrillation, you don't want to shock that because you're going to kill that person. Okay. Same thing with VTAC. VTAC is basically, you can see it's steady, it's regular, it's the same thing over and over again. This is like it's almost as if the ion channels are backwards and you need to shock them and reverse them. Okay, so you can shock VTAC and VFib. You cannot shock a flat line. Not really anything will happen. Okay. You can do CPR until the pulse picks back up. But like, it's not like, okay, clear. And everybody shocks and whatever. Nothing will happen because you're taking cells that the electro conduction is not getting through and you're shocking that. And like sometimes it works, but then other times it like doesn't work. Okay. The other thing you can do, and I learned this in college and I saw it one time and it was the coolest thing I've ever seen, is called a cardiac thump. Okay. Is like literally you take your hands and you just like right there. Same thing because you can reset those ion channels through trauma as well. Which is why if you get hit by a car like in the chest, like what's that football player's name? The guy for the Bills. He got hit in the chest and the ion channels were reversed. He went down and was immediately like heart not beating. Yeah, yeah, it's really cool to watch, right? So all right, I'm gonna get down a rabbit hole. Okay, so one time we used to have this cardiologist that worked at this hospital that I worked at, and I forget his name. He was a huge New York Yankees fan. He drove a Maserati that he had installed undercover police lights on, which is highly illegal. Okay, but we would call him from the ER and be like, "Hey, we got this rhythm from EMS, and this person needs a cath lab right now." And he would jump in his car and turn on his lights, and then he would have like 5 police cars trying to pull him over, and then he'd pull into the physician parking, and they'd all just scatter. And then he would run into the ER and he would be there before the ambulance would get there. And it was awesome. And he was my favorite person ever. And so one time they came in and I was a scribe in the ER. So my job was like the least important person. But they're very important. And I saw that coming in and I was like, hey, Dr. Santina, do you mind if I go watch a cath? And he was like, go. I'm not going to do anything for this guy. And I was like, all right, cool. And so this guy came in, he's sitting up, he's talking. We brought him to the cath lab. He was in the cath lab within like 10 minutes of like hitting the door, which is like incredible response time. And it was gotten because of a doctor doing illegal things, go figure. And then, so we're doing a cath, and this guy, like, he was talking during the cath, and then just like stopped, like just slumped over. And that doc took a fist and he went boom, and this guy went and like woke up and then like started fighting him, and then he punched the doctor punched him in the face and like grabbed him and was like, "Stop! I have a wire in your heart," and shoved him back into the bed, and he stops and he got 2 stents, and it was the coolest thing I've ever seen. Never had so much energy in my life. But you should go watch stuff like that because it's really cool. So you can simulate a shock with a thumb. Um, you can't like just like punch them over and over again because CPR is not working. That's not really how it works. It's like you get like one shot. If you don't do it well, you're not going to get another shot. So it can totally do it. It wasn't rushed. It was the craziest thing I've ever seen. Um, I've probably seen some crazier stuff since then, but at the moment I was like 19, fresh grad. I'd been working for like 6 months in the ER, and like the craziest thing I'd ever seen was like C. diff, and that was wild. So you can totally do that. Okay, first degree AV block. Okay, so this is an AV block. Um, if you remember the any questions on this so far? Where are we at? Any questions on EKG or views or anything like that? No, no, no. Okay. And can I move on? Great. Okay, so first degree AV block. So this is a block between the SA node and the AV node. Okay, so you're supposed to delay that message. Sometimes, depending on where the ischemia is, that message gets delayed a little bit further. Okay, so this is a P wave right here. There's a delay. Obviously, you can see the AV block is like, stop. Okay, go. So he's being a little weird right there. So you're getting a late QRS, okay, and then but a normal T wave. So everything's happening normally. It's just taking a long time. Okay. So that's a first degree AV block. Think of it like where we're at in the conduction system. So this is at the AV node, right? Second degree AV block. So we are, first degree was just before the AV node, second degree is at the AV node. So it's doing it, but it's delayed and it's progressively prolonging it until it just drops a beat. So you'll see this on the EKG. You'll see just a blank flat line, and then the heart will be like, "Oh yeah, I'm supposed to beat," and then it'll like start over. So it's late, a little bit later, a little bit later, a little bit later, a little bit, never got picked up, never got picked up. Okay, picked up. And you might skip a beat or two, right? So like, and it's totally fine. Like you might not even notice that if that happens. You might just be like running around, nothing happened. Okay, cool. Like that's fine. It might be very bad. So yeah, that's second degree heart block. That's a Mobitz type 1. And there's another kind of AV block, sustained place, but it's a little bit further down. So it's kind of a similar style, like the QRS is normal, but you might end up with the PR intervals are not, those are normal. Um, but it's dropped with the QRS complex, right? So if this is elongated, this is steady elongated, this is extending the elongation time. So that's a Mobitz 1. Mobitz 2 is normal PR, but it's getting dropped later during the cycle. So you might not get a QRS complex. So Dr. Burkinji didn't know everything about the heart. So that then they can be graded too, like a 3-to-1 block. So you would have 3 P waves to every 1 QRS. Okay, and that happens at the Burkinji system, or the bundle of his, or the Burkinjis, or something like that. Okay. Third degree heart block is the worst kind of heart block, and it's a complete dissociation between the atrium and the ventricles. So you have 2 rhythms that are just happening whenever they feel like happening, and they're just doing their own thing, not communicating at all. Is it bad if the top of the heart doesn't talk to the bottom of the heart? I'll give you that one. That's a yes. Okay, you got it. All right. So there's no communication, and eventually, like those repolarization times might interfere with each other and then crash into each other, and then the whole heart depolarizes, which is bad because nothing happens. Okay. So if you see like a P wave, sorry, like a P wave, and then a P wave, and then a P wave, and then the QRS and the T waves are just happening like randomly, like anywhere between there that they want to, that would be an indication of a third grader. All right, sinus, bradycardia, sinus. So sinus is normal rhythm, like normal rhythm. Bradycardia refers to the rate. Okay, so brady is slow heartbeat. Sinus tachycardia is a fast heartbeat. Either one of these could be fine. Either one of these could be bad. Okay, so in bradycardia, that'll put you faster than heartbeat, a fast heartbeat. So there's a pacemaker implanted if somebody has like extremely low heart rate. Okay, defibrillators, clear. Um, they're smart, and you should use them if you see something on the ground. Um, the ones that are like in these boxes can detect the rhythm. Like I said, there's only two shockable rhythms, so it'll pick that up, and then it'll go, "Nope, don't shock him. You're gonna kill him," and then it'll shut off, or it'll say shock detected, and then it'll shock him. Okay. Uh, Generally in hospital settings, but they're all over the place. You'll see them anywhere, like if you go to church or like public buildings or anything like that, you'll see defibrillators all over the place. And just know, like, if you open one up, there's instructions and they're telling you what to do. Okay. Defibrillation is really important. It's almost as important as CPR. That's all I got. Any questions? They are easy to use. They're smarter than you, so they'll tell you if you want to use it or not. Any questions? Everybody keeping up on the heart stuff. Any questions? Are we going to do an exam review and go over the cardiovascular system part 3 PowerPoint on Tuesday? We did part 3 on last Tuesday. Remember we did part 1, part 3? To use if you're working in wound care, which is odd. That's like not good. Your wound care team sucks. Yeah, part 1 and part 3 were in the lecture, the last lecture we did. So watch those for part 3 PowerPoint. I think Tuesday we're going to do an exam review, and then I think the exam will be Wednesday through Sunday. Okay. Back in Arizona, but like not really. I've never even been to Arizona. So it'll be like Wednesday through Sunday. It'll be open. So like we probably won't have class on Thursday. I need to figure that out. I'll be honest, I don't really know. I would assume like if we were taking a class and we were using class time to take an exam, which is a normal thing, then we wouldn't have scheduled lectures. Um, so I'm pretty sure that's the case. We get to skip a day, but I will double check. But probably. So have I seen the test yet? Do I know if it's multiple? Um, Slightly. Let me see. Exams on the test surveys and polls. Here we go. Oh, I do have the exam. Let me look at it. I can edit too. It is multiple choice for the first. Oh, let's see. I'm at question 30. It's 40 questions, mostly multiple choice, some true false. I don't see any fill in the blank, so I would assume that it's not that. Spelling questions worry me. There's no spelling on the test. It's all multiple choice. Which units and chapters? All of module 1. So endocrine, blood, heart. Those are some tricky questions. It's this weekend. I'm going to open it Wednesday through Sunday. I think I have at least the power to do that. So we'll do a review on Tuesday. The reason is I don't want to open it and then do a review and then close it. So we'll do Wednesday through Sunday and then we'll do a review on Tuesday. So come with questions. Oh, tricky questions. There's a lot of endocrine so far. You know what? There's also blood typing, which I didn't have a slide for and I didn't think to go over it. So I'm going to post some videos about blood typing to help. And you can read the textbook as well. It's not that hard. Like, it's literally not that hard. But there's a couple questions on it, so I will make sure that you at least get that information. Any other questions? I'm here for another 20 minutes until lab, so if you guys have questions, now's the time.